my name's Steve. I am a respiratory therapist with a bunch of extra credentials, as you can see. I'm currently in Cranfield, England, which is just northwest of London. So I'm over here working on my master's degree. Today's topic is sepsis. I call this the downward spiral because that basically is what sepsis is. If you don't interrupt it, it's going to be like falling down a spiral staircase. It's going to hurt a lot and it's going to have a bad outcome probably. So clinical affiliations, normally I work as an RT. I always say I'm a respiratory therapist with a weird side hustle. But right now, because I'm in the process of finishing my master's thesis, I'm actually on leave, sabbatical, whatever you want to call it. I work in forensics as my other job. I'm actually a master's student in forensic archaeology. So do have some other stuff in forensics. I helped edit the current edition of the Oaks Pocket Guide and the neonatal respiratory care pocket guide that just came out. Cross-training cardiac ultrasound, used to be a flight RT, used to be an EMS supervisor and instructor. Some other stuff that's unrelated. And if you aren't tired of the sound of my voice yet, I actually do a podcast, so called the Skelecast, on true crime and forensic science. So standard warning that comes with all of my presentations is that this contains attempts at humor, keyword attempt, sarcasm, and various historical and pop culture references. Viewer discretion is advised or in some cases encouraged. It's kind of this same old story. I promise not to go overboard explaining this stuff. 3 drinks later, I'm Martin Luther nailing the 95 Theses to a church door. So what are we going to talk about today? Well, first of all, what is sepsis and what is a related syndrome called SIRS, Systemic Inflammatory Response Syndrome? You have to understand SIRS to understand sepsis, and you have to understand sepsis to understand septic shock. They're a progression of the same continuum. So basically what you have is one leads to another. And if you understand the physiology of one, you can begin to understand the physiology of the rest of them. So pathophysiology is very important. I'm a pathophysiology and physiology nerd at heart. And so we're going to spend a lot of time talking about that, and also how this presents, the pitfalls of it in clinical practice, and how we can intervene to try to save as many people from this fate as we possibly can. So what is sepsis? Well, like everything else in science, you have to have a definition of a word that you're defining. Otherwise, 5 or 6 different people may have differing views of what constitutes sepsis versus what constitutes SIRS, things like that. Sepsis is defined as that which is caused when the body's immune system becomes overactive in response to an infection, causing inflammation, which can affect how well other tissues and organs function or work. That's the US national definition for research purposes. So it's a syndrome. Sepsis is not a single condition. It is a syndrome made up of multiple symptoms that can have a varied presentation between individuals. It has a very high mortality rate, and it can depend on how soon you catch it. The sooner you catch it, the better off. You catch somebody while they're still in SIRS, they have a higher survival rate than if you get somebody who is septic versus someone who is fully septic shock. As I said, the clinical presentation can vary depending upon the patient, the point at which you're looking at the patient in their clinical progression, and also the organism or organisms that are involved in producing the septic condition. Or the infection underlying it. So you can have multiple and progressive dysfunctions from organ systems, different organ systems going offline or into overdrive simultaneously or in sequence for one another. It's often described as being like a game of dominoes where you trip one and all the rest of them proceed to fall until something interrupts it. And it's a very good way of looking at it. It's referred to in engineering or human factors as cascading failures, to use a technical term there. So what are we talking about when we say SIRS? Systemic Inflammatory Response Syndrome. It's exactly what it sounds like. It's the body's inflammatory response to some sort of external or internal stimulus that it views as a threat. Generally, you're going to see an increased heart rate, you're going to see increased respiratory rate, and you're going to classically, you see an increase in body temperature, although you can actually see a decrease in body temperature depending on what's going on with the patient. A climb in white blood cell counts, and then also lowering of PCO2 because of increased minute ventilation because your respiratory rate went up. Now that'll be offset eventually to some point when your metabolic rate gets up to a point where you go into respiratory failure. So sepsis is defined as two of those criteria at a minimum. You can have all of them, but you have to have at least two of them, plus a documented infection that is systemic, or more commonly just viewed as being it's bloodborne. It's in the bloodstream. Severe sepsis is a subset of that, where you have a some sort of end organ system signs and functions at an elevated lactate, usually hypotension's here. Some people will separate that out and put it with the presentation of hypotension as being septic shock. Basically, the body's compensatory mechanisms are no longer functioning. But so if you have like an altered mental status, you have renal failure, oliguria, anuria, things like that, and an elevated lactate, that's severe sepsis. Some people, like I said, will put hypotension in there. To me, that defines it as septic shock. That's the way I was taught to view it. So septic shock, everybody views it this way, whether or not they lump in the requirement for hypotension or not. It's basically where you have persistent and progressive signs of end organ dysfunction, altered mental status where the patient is not just kind of coming and going out of consciousness, they're fully unconscious, or their kidneys have completely shut down, or their coag is completely messed up. Once you get into septic shock, your mortality rate skyrockets. This is why the sepsis survival campaigns have been focused so much on early recognition, because once you get to the point of septic shock, you have a less than 50-50 chance of survival. So you want to get these people taken care of as quickly and identified as quickly as possible. So another way of looking at this same way, you can notice how this has the gradation that I've always taught of, septic shock is defined persistent hypotension in addition to severe sepsis. Basically, your compensatory, it's decompensated shock at that point. It's what it boils down to. Like if you think about compensated hypovolemic shock versus decompensated hypovolemic shock, it's compensated sepsis, septic shock. That's the way I've always been taught to view it, and that's the way most of the people I've worked with view it. So how severe a problem is this? Well, as you can see here, STEMI, so your heart attacks, your strokes, your severe sepsis, and a ruptured abdominal aortic aneurysm. So basically, you're looking at survival. This is a much greater threat to a patient's life than a heart attack statistically. It's not to diminish the threat of a heart attack, but statistically, you're more likely to survive a heart attack than you are severe sepsis. And the thing is just like, a lot of heart attacks are given, the patient had pre-warning signs of before the actual, widowmaker heart attack. You have patients who are showing red flag symptoms. And if you don't recognize it, that's when they get into this mortality where there is just a humongous amount of you're behind the curve and you're fighting to catch up. So what you have to have happen is you have to learn to pay attention to what's happening. There's one of the docs who trained me always used to like to say that sudden onset is usually more often delayed recognition. Very few times is something truly sudden onset. His example is lightning strike. But he always said that, very few things are lightning strike, sudden onset. Most things have symptoms that lead up to it, especially medical problems. But basically, once you get to the point of severe sepsis, you're dealing with the clinical equivalent of this sign. Soft shoulders, blind curves, steep grade, big trucks, good luck. You're on a downhill run, and if you better hope your brakes work. In this case, the antibiotics, suppressors, everything else you're giving that patient to try to keep them going until you can get the infection under control. So it's a very problematic thing, and it gets into this very, very, very rapid, often spiraling decline. So now the problem with a normal inflammatory response versus SIRS or a sepsis is the difference between a positive feedback loop and a negative feedback loop. A positive feedback loop will basically make things worse and worse and worse and worse, often exponentially. And the problem gets out of hand very quickly. You don't want a positive feedback loop most of the time. There's very few situations where this is helpful. There's a lot of situations where it's destructive, incredibly so. What you want is a negative feedback loop where basically they work, the processes work to bring everything back to homeostasis in the case of a body or an organism or a cell. And it basically brings everything back and cancels one another out. So the example I can always use to get what a positive feedback loop how destructive it can be is the case of the Tacoma Narrows Bridge, better known as Galloping Gertie. They've since rebuilt this bridge. It made it so that it didn't do this. It's what's called aeroelastic flutter. This is a solid steel and concrete bridge, and you can find the video online, and it looks like water rolling, like waves rolling across there, because they didn't make the bridge stiff enough. And basically what happens is that bridge gets into what's called mechanical resonance, where the input from the airflow is making the mechanical response that results from it worse and worse and worse. And it builds and it builds and builds until something gives and the bridge collapses. Or in this case, with sepsis, these things spiral and this trips off, this endotoxin over here trips off this problem. Well, this inflammatory marker over here trips off this response, which trips off this response, which trips off this response. And next thing your blood pressure is plummeting, your heart rate's spiraling down, you're in respiratory failure. You see how all these things build upon each other in a negative feedback loop. These things may or may not be interrelated normally in the way that they're functioning here. It's when things get outside of the norm where you're not. This is where things get really, really, really screwy very quickly. And it's why it's often these patients present with seemingly bizarre findings, such as like hypothermia. You'd think a person with a massive raging infection is going to be having a response that's due to the response is going to be a massive fever. Well, the person's massively vasodilated due to endotoxins or exotoxins from the bacteria or from other factors. And basically the person's losing more heat to the room than they are producing, no matter how high their metabolic rate is. It's a really complicated process. There are still people who are trying to figure out how some of the minutiae details of human temperature control work, because it's still not completely fully understood, believe it or not. It's actually really interesting. There was a professor at a university I used to attend. That was one of the things he was working on. And it was he was working on it for the purposes of improving therapeutic hypothermia. So normal response to an infection is a very controlled, it's non-specific. It's not this antigen goes after this target or this antibody goes after this target. It's we're gonna like go in and kick the door in SWAT team style and just everybody's on the floor until we find out who's causing the problem here. You know, it's that sort of a response. You end up with vasodilation, increased vessel permeability. This does two things. One, it increases oxygen to the tissue, so a lot of bacteria do not like oxygen. You know, your anaerobes. The other thing is it helps tissue perfusion. It allows inflammatory markers and antibodies to get into an area and do their job. All of your cytokines, things like that have to get in there to trigger the healing response or the immune response against it. An invader have to get in there. Also, fluid gets in there as well, helps to wash out whatever's there, and also allows you to get things in you need. It's just like opening up like a farm road when you're plowing a field. You have to have a way to get the tractors in and out, and the seed and everything else you put in. So this is why you get a warm, swollen area around an infection or inflamed site, is this response right here. So normally what happens after the infection or whatever else is going on, it triggers this inflammatory response, the tissue heals, and the system shuts itself down. Now, sepsis is an unchecked version of that. It's excessive, it's out of line, it's a positive feedback loop. Things keep making, each step makes the next one worse or triggers the next one rather than slowing it down. So it's like the French Revolution. Things go completely off hand, and next thing you know, the people that are the markers and things that are supposed to be in charge are no longer in charge and are completely offline, if not missing their heads. So you have all these problems. Or the other way you can look at it, and I apologize to anybody who's from Philadelphia for this next slide, is, it's always septic in Philadelphia. It's the Danny DeVito. So anyway, I just started blasting approach. Anything it's, to solve the problem. It's just wipe out everything in the area. Well, the problem is you might wipe the person out in the process. Damage a lot of tissue that you don't need to damage. And the body the inflammatory process gets out of control. And you can actually have it to the point where basically the mechanisms that are supposed to keep the infection in check in an area, in one area, end up spreading or end up not keeping the infection from spreading, because the swelling may be so great that it ends up producing tissue spread and causing things like that. That's why if you watch an infection spread up somebody's hand, it'll spread up along the lymph ducts and stuff, because lymph vessels carry detritus and debris back. And if it's not being taken care of at the site and being carried along, it can be transmitted that way. Basically, it's asymmetrical warfare. So basically, you have one side that is using a reaction to another, or an infection that's starting an attack, and then all of a sudden, bam, you have an overwhelming force come in, and the overwhelming force is actually the body's response to it. The way to look at it is like if you're old enough to remember the Falkland Islands campaign, when the Argentinians decided to try to take back a British islands off the coast of South America, the British just wiped the floor with them because the Argentinians were unprepared. And then there's this show called Bluestone 4-2, which there's this sign, and it's like, we should embrace our Argentinian friends, right up until unless they try it on again, in which case we brass the expletive up, so it's a really good comedy about an EOD team in Afghanistan, but that's the way I've always described asymmetrical warfare. So how does this cause all these problems? Well, the big one is endothelial damage. So the lining of blood vessels, lymph ducts, things like that. You have basically, the good way to think of it is that the capillaries are made up of a single layer of cells. And if they don't line up perfectly end on end, you end up with like the equivalent of having like a piece of sidewalk that's sticking up. And if you're walking along bare feet and you stub your toe, it damages the blood cells that are going past. And also those cell ends have markers on them that say, hey, over here, we're damaged. We need clot. We need clotting factors, which sets off a clotting cascade, which in turn sets off other things, other inflammatory responses in and of itself to repair that normally, but it also causes other problems. The other thing is that it's just like if you have a bunch of pieces of pipe that are stuck together, if you have like two pipes that come apart and start leaking, there's going to be more fluid loss into that surrounding area. The same thing happens with endothelial damage. This is why people that are septic tend to swell up. And you have the pooling of fluid in various places, depending on if it's in the tissue, if it's in body cavities, things like that. But there's other things that can happen with coagulation systems that are due to endotoxins, exotoxins, reactions to the medications we're using. But it's one of those, it's commonly a depletion of the clotting factors. So you end up with DIC, disseminated intravascular coagulation. And you basically end up with a thrombocytopenia or something along those lines, where you're basically eating up your factors in places you don't need to be eating them up. Clostridial infections, so Clostridium perfringens, which is actually the cause of gangrene and human decomposition, is really notorious for this. They produce, I think there's 7 or 8 major types of that bacteria. One of them, type D, is well known for producing intravascular coagulation. I've actually seen it in a blood tube where the red blood cells were stacked in little clumps within this tube, which has, a very potent anticoagulant in it. You could turn it and just watch the blood cells fall out of solution. It was the strangest thing I've ever seen. That patient didn't live long, obviously. Endothelial damage can be due to either the body's responses, or it could be due to the toxins of the bacteria, or it could be due to other factors as well. Cell mediator, which are basically just chemical messengers that kind of say, hey, come over here and do this. I need you to come here and do this. Well, if these reactions get out of line and get out of hand, you can trigger responses against tissues that don't need to be targeted. And so you end up with that. And then, like I said, direct bacterial toxin effects, some endotoxins that are produced by like the Clostridial family of bacteria. So Clostridium tetani is the one everybody thinks of, but it doesn't, even though it tends to not, it doesn't produce sepsis in the way we normally think of it, it does have a very potent toxic effect, which is tetanus. That's a very good example of that. But you can see things like clotting cascade activation. You could see things along the lines of vasodilation, with a very pronounced hypotensive response to some bacteria. And then there are endotoxins, which are within the bacteria and are released when the bacteria is killed. So that's counterproductive. Or exotoxins, which are produced to keep other bacteria or the immune system from coming after the bacteria, or a parasite in some cases. So you have a number of basically overlapping and linked factors that can cause all these mechanisms. And these mechanisms each can present differently depending on what else is going on with the patient. This is why we get such a weird presentation in some septic patients. So I always tell people that coagulation factors can be thought of as akin to explosives. They're very helpful if they go off at the right time in the right places. If they go off at the wrong time or in the wrong spot, it's not something you want to have happen. And so it's, you have to have that. What can we do with this? What's going wrong here? And of course, but people know I use South Park, something similar. For this coagulation dysregulation, you're going to have a bad time. You are. So what can cause this? So SIRS is not necessarily an infectious process. This inflammatory response does not have to be due to an infection. You see this in trauma patients. You see it in people with pancreatitis. You see it in people with burns. You see it with people who have had major orthopedic surgery sometimes, which is trauma technically. The orthopedic surgeons don't like to think about it that way. So the other side, you could have an infection and not have SIRS, or not have sepsis. And you could have infections from parasites, prions, fungi, bacteria, all sorts of things. Basically, you name it, it can probably, something in it will cause an infection. Something in that family will cause infection at some point. Most bacteria are not human pathogens, at least not under normal circumstances. Now, what differentiates an infection and SIRS is there has to be a systemic response, which generally means that there's going to be a blood-borne infection. That's that pink area that's labeled sepsis. This is why people think of sepsis as blood poisoning in the old terms. In the old terminology, you'll see people died of blood poisoning, they died of sepsis, a septic shock. Basically, that's where the two overlap. You can have one without having the other, but if you have both of them together and it's a systemic infection versus a localized infection, you have sepsis. That's the way to think about it. But there's all these other causes. People think of bacteria because it's the most common and it's the most easily treated. But you can have viral sepsis. You can have parasitic sepsis. Malaria is a good example of that. There's a thing called cerebral malaria, which is a nightmare condition in my book. Fungal sepsis. You can see that in some people who are massively immunosuppressed, particularly. So what are your risk factors for this? So recent medical interventions. So anything you've had done to that person or is done that breaks or bypasses the normal protective barriers. So basically anything invasive, surgery, IVs, blood draws, Foley catheters, intubations, and mechanical ventilation. People who are ill, obviously, if you have an infection, not only could that infection cause a problem, you could also knock down your immune system and prevent you from fighting something else. So if you've had the flu and you step on a dirty piece of glass and cut the bottom of your foot and end up with a wound infection, your immune system's already knocked down from taking care of the real bad case of flu you had. It may not be able to fully respond to the other infections. Pregnancy and childbirth. There's a reason why we learn to wash your hands. That's a guy named Ignaz Semmelweis, who realized that childbirth is basically produces a big open wound. So there used to be and it still is actually a problem. It's called puerperal fever or childbed fever. It produced sepsis because of the fact that you had less than hygienic conditions for childbirth and delivery, and women were getting infections from it and dying from it, becoming septic. And he realized that there was a link between, believe it or not, between people or medical students who were attending childbirth and then going and doing autopsies and then coming back and not washing their hands and delivering babies again. So as disgusting as that sounds, that's how we found out that hand washing is very important. That seems so nonsensical. He literally used a bleach solution. And he actually got very hard pushback against this because people took it as an insult. The doctors didn't want to be told they were killing their patients. I mean, nobody wants to be told they're making a mistake that cost somebody else their life, but still. So other risk factors, extremes of age, people that are very young and very old both need much more careful assessment before ruling something out. And this isn't just because of communication issues, it's because they often don't have the reserve that we do, that like a healthy 35-year-old has. People who have developmental delays, your patients with Down syndrome or traumatic brain injury patients, or anybody who has a communication issue, whether it be a stroke, a TBI, anything along those lines. If there's a communication issue, they can't tell you what's wrong. It becomes much more difficult to rule everything out. So you have to be much more cautious with these patients. And much more thorough. Of course, I always tell people you should be as thorough with everybody as you would with a patient who can't talk to you. Just be safe, but people look at that as overkill. And of course, risk factors, diabetes. And this picture freaks one of my friends out every time I show it. So she cringes every time she sees it. Wilford Brimley and diabetes testing supplies. Yes. Cirrhosis is a risk factor. For a multitude of reasons. One, patients who are cirrhotic tend to also have other complications because a lot of them are alcoholics. Their nutrition status is not great. So they don't have, that affects their immune system. So you have a higher risk there. Also, if you have somebody who is cirrhotic, their coag factors are probably at least a little off to begin with, because the liver produces a lot of those. And so if your liver's not functioning properly, you're not going to have appropriate coagulation. If you ever work in a hospital that does liver transplants, look at how much blood they take in the OR, typed and crossed, and how much plasma they take in, typed and crossed for these patients. It's insane. Because they are, if they are in liver failure, they are in bad shape, coag wise. Immunosuppression. So if you have a patient that is immunosuppressed due to chemo, HIV, post-transplant, things like that, chronic steroid use, splenectomy, or somebody who's born without a spleen called dysplenia. Those are all things that increase your risk factors because you're not going to be able to fight off the infection, keep it under control as readily as you might beforehand. And then people who have autoimmune conditions, they're already prone to their body's immune system overreacting or inappropriately reacting to things. So it's the whole, hold my poodle, like this should not be a big deal. It suddenly turns into a huge argument fight. And things like rheumatoid arthritis and lupus and things like that, these patients tend to have a systemic response to things much more readily than a person who does not have those conditions. So cancer, obviously, for a number of reasons. One, these patients often have a lot of invasive things being done to them. Their skin's often damaged due to radiation therapy. or nutrition issues. Their immune system may have taken a hit from the chemo, from the radiation, from various other treatments that they're having. Sometimes their clotting status is not fantastic because of like radiation therapy. Also, just the emotional strain and the physical strain on the body from having a cancer diagnosis can put someone at a disadvantage. Patients who are paralyzed, this goes towards one, hygiene, also the ability to detect a problem early on. They can't tell you something hurts. They can't tell you that there's a wound that's getting infected. This is why you have to be very careful. This is the same thing as if it's a chronic paralysis versus you've paralyzed that patient and knocked them unconscious. Treat that patient the same way. You treat them and you become obsessive about skin. And that's why it says compromised skin down below. But you have people who basically also ineffective airway clearance is a risk factor for respiratory infections. We all know this. Same thing goes for, a lot of patients who have paralysis also have swallowing disorders. So if they're aspirating on that regard there, people who have sickle cell disease have increased risks of this. Oddly enough, sickle cell is a trait that developed to protect people from malaria. But if it has a side effect of causing problems with, coagulation and various other factors. So it gets very, it actually is a risk factor for sepsis because the cells are more fragile and they're also more prone to clotting because of irritation and triggering of the various factors that set off the clotting cascade. So you have compromised skin, obviously. It's a big open wound. It's going to be a risk for an infection and therefore sepsis. So you have your diabetic foot ulcers, you have your burns, you have chronic unhealing traumatic wounds, things like that, bed sores. So all these things, all the places that you can think of lodging an infection is going to be where that infection is at is going to determine what signs and symptoms you may have. Unfortunately, these are not very specific usually, and you can have a number of things that cause very similar symptoms, and they can vary and depend on the patient's underlying health status, what medications they're getting. You can have medications that mask an effect or worsen an effect or exacerbate it and cause a problem that would not normally present at this point in the situation. So really the signs and symptoms may not be that helpful at all, but they should set off make the hair on the back of your neck stand up and go woo, woo, woo. And then you start looking more intensely. Don't write things off. So fever is always the classic sign of sepsis, infections, things like that. However, in patients, especially in the elderly, it may not be present. And the cure is not cowbell, by the way. So actually, a patient who has a body temperature that is low, below 36 Celsius or 96 Fahrenheit, it's actually a much more ominous finding. It's not quite we're boned, but in the famous quote of Bender Bending Rodriguez, but it is an ominous finding, especially in an elderly patient. The patient's no longer compensating to keep their temperature up. So you can have malaise, flu-like symptoms. Malaise from the French word for I feel like crap. Chills, nausea, vomiting, mental status changes. You have a mental status change in an elderly person, it is not due to sundowning until proven otherwise. It is a red flag if that patient's mental status changes even a little bit. Unless you know that patient and it's documented that they do this, and even if it is, they suddenly change and you have to pay attention to it. Dig a little deeper. Don't just blow it off, because you blowing it off might be what kills that patient. So if you have a hyperglycemic episode in a patient who is not diabetic, especially if their CO2 level is low, that's an immediate, hey, over here, everybody get the antibiotics and get in here. Because hyperglycemia is one of the early systemic responses to an infection, because your body needs all the energy it can to fight this infection. So they're going to spike their blood sugar. So basically what's going to happen is you have that. So if you have a patient who's hyperventilating and blowing their CO2 off, and then they've got hyperglycemia on top of it, they're not diabetic, are they? No. Okay, well, we got to start looking at some stuff here. So if you have a patient who's got poor capillary refill and either they're weak pulses or they have a very sluggish but bounding pulse where it's boom, boom, boom. If you feel this, you'll know what it's, it's a feel. You have to feel it to understand it. I always have a hard time explaining it. It's bounding. That's the only way to describe it. But it feels like a boom, boom, because they have no tone between that. And so the only pressure that's in that vessel is whatever the impulse coming through with each heartbeat is. So you get this boom, 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 boom. It's caused by a widening pulse pressure. Basically, your diastolic pressure's dropped out, your systolic pressure's stayed where it's at. And so you end up with a widening pulse pressure and you end up with a bounding pulse between the two. Decreased urinary output's a big red flag. Something's going on with that patient. Even if they're not hypertensive, that's a bad sign. Tachypnea or hyperpnea. So basically the patient's hyperventilating or is breathing very fast and looks like they're moving more air. If they look like they're sucking mud, they're sucking mud. Now, not all patients are going to look like they're sucking mud. Now, of course, if they're hypotensive, it's going to be there. So if you have a patient who has tachycardia is one of those non-specific findings we see all the time, and most of us brush it off. But if something doesn't fit, especially with the patient's temperature, you get a patient who's cold and they have a heart rate of 120, something's not right. Cold patients usually slow. So what's going on here? Let's start looking for why that's happening. I always tell people that the best clinicians are the kids who never had the habit of asking, but why? Beaten out of them as small children. Case in point, like my mom hated me when we would go, I would have a question, but why? She's like, okay, just go to the library and look it up. So, people are, you have to have that innate curiosity, but if something doesn't fit, don't accept it. So you can have a patient that is modeled and cool, or you can have a patient that looks like they're very flushed and ruddy looking, depending on what point in the condition you're looking at them. So basically one of the reasons why a low end tidal, even if it's side stream off a nasal cannula, if you're getting a chronically low CO2 on somebody, that's correlating, especially in a patient who's, got other signs of an infection, that correlates with a high lactic acid and predicts mortality most of the time. So that's one of the reasons it's worrisome and why you have to be on guard for it and why you should be monitoring these patients a little more aggressively than a lot of us do as a matter of course, because we don't want to be seen as overreacting. So patients may not appear to be seriously ill initially. We've all had patients who have crashed on us abruptly. They looked like they felt kind of bad, but they didn't look ICU sick, basically. They didn't look like they were going to die in the next few hours. And then they turn and you end up with multi-organ system failures. And you end up with, your blood pressure bottoms out, they stop producing urine, they start having consumptive coagulopathies, and then end up with petechiae and purpura, which can either be due to DIC or it can be due to an endotoxin. That's why people who have meningitis tend to get purpura. And purpura are just big petechiae, by the way. A petechiae is, I think it's less than 1.5 millimeters in diameter. Purpura is bigger than that. And a purpura that's bigger than, I think, 5 millimeters is just ecchymosis. So, but you can have your coagulopathies if your liver shuts down, if the patient turns jaundiced. You can have patient, obviously have your lactic acidosis that produces, you can do a number of factors and trigger a lot of these other things. And it's like a map of factors leading to the First World War. It's all these other things that led into a problem that should not have been as bad. And it suddenly turned into something that results in a lot of death and destruction. So you may have other symptoms that present based upon the underlying etiology. If you have a patient who has pneumonia, they're going to present differently than a patient that has gangrene or peritonitis or C. diff colitis, which produces sepsis more frequently than a lot of people think. UTIs, bacteremia and endocarditis from IV drug use, things like that. Got a patient that has splinter hemorrhages. They look like a piece of wood embedded up underneath the fingernails. It's pieces of the clot and vegetation that grows on the it's not actual vegetation, just what the term they use for it, on like the leaflets of the cardiac valves that break loose, and then it lodges in different places in the vascular. You can get it in the eyes, you can get it in the fingernails. They're the most common spots to see it. It's a giveaway for IV drug use, and or at least endocarditis usually. But you're going to have different signs and symptoms for these things depending on what's causing the underlying problem. A pneumonia patient is going to present with pneumonia symptoms. If you have a patient that has gangrene, you're going to smell them before you walk in the room. It's a doorway diagnosis, not a driveway diagnosis, to use the EMS term. Often UTI is the same way. You can smell them, especially if if the nurses just drained the Foley catheter bag. So this is actually taken from a EMS protocol from the state of Arizona. And it's basically, when you have a patient that presents, who do you flag as possible sepsis? Do they have any of these things? And if anybody wants this paper, I'm happy to give you a copy of it. But it's like, do you have a suspected infection or immunosuppression? Do you have any of these other factors, things that cause risks? Do you have the suspected infections? Okay, just email me. My email will be up at the end of the slide, and I will get you guys a copy of this. I'll happy to email it to you. So, or you can email Keith and he'll email me and I'll give it to him. So, all right. So, but if you have a temperature abnormality, or if you have any of these high risk factors, now, let me see here. Markers of the systemic inflammatory response: glucose of greater than 140 in a non-diabetic. CAP refills. This is a pediatric score. So if you can use this in a kid, if something is messed up in a kid, it tends to present, the kid's not acting right, is a common complaint in kids that are going to be septic or becoming septic. A kid with petechiae who is confused or altered is one of those things that makes every opening in my body tighten up very, very harshly, very quickly. It scares the ever-loving crap out of me. No matter how long I've worked in pediatric ICUs, it scares the ever-loving crap out of me. Petechiae in a kid is one of those things that you see it and it leaves an indelible mark. Because classic findings meningitis, but it can be other causes too. Findings of shock, and then most of those purpuric rash, like I said, big petechiae. The big model, they look like usually about the size of a dime, maybe a little smaller. But systolic blood pressure, these are kids' criteria with a little there on the side over here. Like I said, this is a really good little thing to keep in your back pocket. I actually have this printed out and it's in my lab coat. So pitfalls, where are our pitfalls in all of this? The big one is not recognizing altered mental status as a sign of end organ failure. Basically, we're not taking a very glaring sign as seriously as soon as we should. The patient who goes completely unconscious obviously is going to get our attention. The lady who's a little off or something doesn't seem right. We all have our frequent flyers. We all know their mental status. That's off, and you walk in and they're not making sense, or they're just not their normal self. That should set off your warning bells. That should be like, okay, what's up with Mr. So-and-so over here? Hey, have you given him something recently? You come out and ask questions like, has he had like Benadryl or something? And he's all loopy, just come out and ask questions. Look at the chart, find out what's been done, what's going on. Look at the results of the chart. Maybe the doc hasn't seen it yet, and it wasn't a critical value, so it wasn't called in yet, but his white cell count's starting to climb. Things like that. Not checking temps accurately. If you have a patient you suspect sepsis, you're not using an axillary temperature on this person. It's a rough guess of a body temperature. You might as well just put your hand on the patient and go, yeah, they feel kind of warm. End-tidal CO2 is not checked and trended. If you think this patient's not doing well, they're altered, you want to know what their CO2 is. I mean, you don't necessarily have to go for a full blood gas, but put a side stream capnography on them and see what they're doing, and keep a check on it and see how the trend is running. That's going to be what's going to decide your um, uh, is often going to give things away. I mean, the patient may have it temporarily, but if it's staying low chronically, something's up. So you have beta blockers can inhibit a tachycardic response and delay recognition of sepsis. It also obviously makes things much more difficult when you have to get to the point of giving pressors and trying to resuscitate these patients. You also have the pitfall of discouraging both ourselves and others from being suspicious of patients' conditions and being aggressive in investigating and intervening. Don't be that person. You want to be the person that stands up for your patient. Don't go set and make your job easier. And I always tell people high index of suspicion consists of when everything's going a little too well, you think it's suspicious. It's the joke is that everything's going well, you're walking into an ambush, or everything's going according to plan, you're walking into an ambush. That same thing goes for healthcare. Is you have to be suspicious of that. The only truly stable patient is the one who's discharged home 2 days ago and is doing well. Now, early to bed, early to rise makes a person healthy, wealthy, and wise. Well, early recognition and a whole lot of fluid resuscitation and aggressive use of antibiotics keeps patients from dying from sepsis. This is a graph showing time of onset from recognition of first symptoms. Retrospectively, they went back and tried to figure out what the first sign that they had that indicated sepsis was to the start of antibiotics, how quickly the patient will be, how likely they are to respond. If you take 36 hours, you basically have 100% mortality rate. Okay, so someone said their sound keeps going in and out. I'm going to see if I can get I'll double check my connections. Okay, hopefully that's better. So, all right. But basically you have this issue with there being, the quicker you get the response, the therapy going, the better off the patient's going to be. Now, the ultimate intervention is not having to intervene. It's like the fire service. They almost put themselves out of business in the US, but through fire codes. Like 90% of their calls are EMS related now. If they wasn't for that, they wouldn't have all the big shiny trucks. But if you prevent it from happening, that's where you wind up with best outcomes. Okay, so basically, an ounce of prevention is worth a pound of cure. So early weaning from vents, this is our big one. Get the patient off the vent, get the trach out, get the ET tube out, discontinue any unnecessary IV access or Foley catheters. There we go. Minimize skin breakdown, skin checks on your patients. I don't care if the nurses are doing it. You look at your patients too. If you move their arm to put the pulse ox on them, look at their elbows, look at the back of their hands. Those little breakdowns, those little tears you get from tape in elderly patients, those can get infected. It may not be the source of the infection, but it may be something that grinds that patient's immune system down and allows something else to get out of check. And oral care. I am obsessive about this with patients. We used to be a joke that it was like a patient was getting Q1 hour oral care between me and one of the nurses I used to work with who was the same way. Turned out she just had a thing about teeth. She was obsessed with her teeth. Her parents are both dentists. So every time she went in there, she would do oral care on the patient. Every time I went in there, I was doing oral care on my vent patients. And so the patients came out with better teeth than they went in with. So oral care, that's the one thing that we tend to kind of overlook in ventilator-associated pneumonia prevention. Some people are really big on it. Some people don't want to do it at all. Some people just kind of go through the motions. I can tell you, someone who's been intubated on a vent for a short period of time, your teeth feel absolutely nasty, even after a short period of time. You don't want to do that to a patient. It makes you much nicer to patients once you've been on the other side of it. So Rapid identification and treatment. I sound like a broken record on this one. Fluids, antibiotics, care bundles, sepsis alert teams. Everybody has a sepsis team in their hospital probably nowadays. I think it's a requirement actually. But are we actually using them the way they should be used? If this is a day shift thing and chart review and they leave nasty little notes for people, is that really doing anything good when you have a time sensitive intervention? No. No, it's not. It's not really doing anything good for them. Maybe we need to start not necessarily having an overhead page for, a sepsis alert, but that's overkill. But, maybe we need to be calling in specific people at specific points when a patient meets certain criteria and specific people come in and take a look at them and specific things are triggered and specific things are done. And this should be being done, but I can tell you from experience, it's not being done in some smaller hospitals because of staffing issues. But the thing is that, if you fix this problem out on med surg, it doesn't become a problem and you're not straining your ICU staff even more, or if you fix it in ER, you're not straining your med surg staff. That's where this stuff gets helpful. It may seem like a lot of work at one point, but it prevents more work down the line. And we're all on the same team here, and we're here for our patients. We're not here for ourselves. If you're here for yourself, please find a different line of work, by the way. So early access, this even goes for your people, those of you who work in emergency rooms and deal with the EMS crews. There's a lot of research that says that aggressive fluid resuscitation and sepsis in the pre-hospital environment and pre-hospital crews alerting the hospital that they have a potential septic patient coming in improves outcomes. So basically, you have your notification of hospitals, the patients with sepsis or potential sepsis before arrival. This reduces time to initiation of antibiotics and targeted resuscitation. So basically, it's the same thing as a STEMI alert. It's a sepsis alert. You're bringing a patient in who may be septic. It means the doctor sees them immediately. They're not being put, because there's seemingly minor symptoms. The triage nurse she may be distracted by that gunshot that just came in. And suddenly you roll in with this little old lady from the nursing home who's running a low-grade fever. The nurse may not be, we all know that the triage nurses sometimes don't listen as well as they should to our reports. And so they end up with the patient sitting out in a curtained exam room. It takes the doctor 2 hours to see them. And they've been sitting there getting worse and worse and worse. So, this sort of intervention of, hey, heads up, flag this patient needs seen now, it helps. So impact of EMS, and another study here, same thing. It helps. It really does. Be aggressive and advocate for your patients. This is one of my key things. You hear me harp about it all the time if you listen to my presentations. You're here for your patient. You're not here for yourself. You want to make sure your patient is, this also includes things that you can't do yourself. Find advocates, find like-minded people among the staff who can do other things, the nurses, the docs, administration if you need be, and get them to work with you to bring about care from the point that they first encountered the healthcare system, like EMS, they dial 911. You want them getting the same level of care you would provide in hospital to them while they're on their way to the hospital. If you could fix that problem early, you're going to fix that problem better. And if those folks can fix that problem, you need a selfish reason for it, which God, I hope you don't. If they fix it early on, it is less work for you guys. It's less work for us in the ICUs and stuff. It's, if the patient's in better shape early on, they're better shape when they come to the floor. So if you have a worrisome finding, especially temperature, that gets communicated directly to an attending, especially if it's a sharp change. Something is going, even if you have to walk up to them and go, I'm not sure what's going on here. Something doesn't sit right. Say it, just say it. We all have that. We don't want to be Chicken Little, like sky is falling, sky is falling, sky is falling, but sometimes we need to be. And the more experience you get, the better you will be at differentiating these. And I always tell students, I will not gripe at someone for bringing a patient's condition to my attention while they're on clinicals or even in regular practice, because I don't want them to hesitate on this. So bring it up to someone who could fix the problem. Usually that's the attending. If the attending's not there, or you can't get them to take you seriously, go to the house nursing supervisor. Nobody in their right mind goes against a house nursing supervisor. I don't care if you're chief of staff of the hospital, the nursing supervisor can make your life a living hell. So what we practiced here, constant vigilance. You have to be on watch, on guard. These are serious matters we're dealing with here. So identify the source of the infection and go after it. If it's a UTI, you pull the Foley. If it's a patient has IVs, replace them. Culture the catheters when they're removed. Same thing for central line, stuff like that. Monitor fluid balance, control temperatures, monitor ETCO2 trends. Vasopressors will likely be necessary, especially once you get into more advanced cases. There's some evidence that says dopamine may be associated with lower survival rates. Norepinephrine tends to be the better choice. So obviously there's this joke. I stole this from another friend of mine's, who's an ER doctor's slides. He made this, and I was just I thought it was too funny to not use it. Adrenal insufficiency is a cautionary tale here. It can present just like sepsis, and the treatment is hydrocortisone or solumedrol, methylprednisolone, rather than antibiotics. This is one of the reasons that adrenal insufficiency has a higher mortality rate than it probably should. People mistake it because it can present like sepsis or a couple of other different things. So there's people tell people to be cautious about this and on guard for it. Salicylate toxicity can produce so aspirin, Pepto-Bismol, Bengay, things, Aspartame, things like that have salicylates in them, can produce a pseudosepsis syndrome. Myxedema coma, which is a thyroid condition, can also be caused by sepsis, or it can present like sepsis when sepsis is not present. So I advocate for checking everybody's thyroid levels if you have a patient who's septic or looks like they might be becoming septic, because this is a problem that can be addressed. And anybody who wants more information on myxedema coma, this is a good link for it. I'll leave that up for just a minute. If anybody wants to write it down, myxedema coma is a really, really, really unpleasant condition to have to deal with. So if you have any questions, any comments, concerns, now's the time for that. So if you'd like to know more, there's my email. Or you can email Keith, and Keith will put you in touch with me. So comments, questions, concerns, anything like that. And I'm going to hand it back to Keith now. So.